Hello, everyone, and welcome to another Unfiltered production. And this one is on a subject that is near and dear to everyone's hearts that subscribes to K&K's newsletter and blast emails. It's about face-to-face again. This one is about the face-to-face dilemma, and I have brought two experts with me that deal with face-to-face compliance on a daily basis. I have Jackie Curry, who is the Director of Operations for K&K Healthcare Solutions. She's been with us for 6 years and looks at charts all day, every day, asks for additional information from clients all day, every day. And I also have Terry Greenhall, who is the owner of T&M Healthcare Consulting. She does audits and appeals. She's been in home health, guys, for 30 years. She is a nurse. She understands documentation, and her passion is compliance and assisting agencies get through denials and review in a timely fashion so that you can keep your money. So Terry is a name you want to remember in case you get those denials and those audits. She is an expert, and she actually really enjoys doing this work, which is something that we have to do, diagnosis on later, Terry. But thank you guys for being on our podcast. And Jackie, you told me
Yes.
once that on your tombstone will say face-to-face compliance. Talk to me.
No, it's going to say no valid face to face.
Okay. What is it that what is first? Let's start with what is a valid face-to-face.
A valid face to face is a document that comes from the referring physician, whether it's coming out of a SNF, a rehab facility, an office visit note, and it basically identifies from the physician the primary reason for referral to home health, and reason being diagnosis, not muscle weakness, gait instability. It needs to identify the disease process that drives that. It needs to address homebound status and why they're homebound. And it needs to have the physician attestation stating that I, physician, met with this patient face to face to discuss these issues, and they understand what's going on, and it's dated and signed. So
And
that is a valid face to face, which means a lot of documents that come over can be valid face to face if they have all three pieces.
it gives us a wide time frame. We get 90 days prior to the start of care and 30 days after. What dilemmas do you see with agencies that have what they consider a face-to-face, but then when it comes time to do the coding of a new plan of care for home health, they think they have a valid face-to-face, but what oftentimes are some of the things that you see that has you send it back and ask for more information?
It could be an office note that doesn't have all three things, but the biggest issue that I see a lot of times is the document that is labeled as face to face or noted to be the face to face. It's within the 90-day time frame. But say that face-to-face is on the hospital discharge summary, and they didn't come directly home. They went to a SNF or a rehab facility, and they were there a week, 2 weeks, 3 weeks. And that facility is actually the referring facility, not the hospital. So just because you have the face-to-face elements in the hospital documents does not mean we can use them as the valid face-to-face, because it must come from the referring facility, certifying physician who's going to be signing off on the plan of care, whether it be the primary care physician. Um, so it's, even though the date for the 90 days before um, might be valid, it still might not be a valid face to face because it's not coming from the proper facility, which is why they give you the 30 days following the admission to get that document, because you might have to get that patient in to see a physician or their primary care. Say the certifying physician hasn't seen them for 6 months. So you got to get them in to see the doctor to get everything confirmed for what they're being referred for.
Well, what I'll often tell our clients is get them a doctor to them. And there's a lot of home visiting physicians that are setting themselves up, and mid-level providers in the states that allow, that are setting themselves up as a provider that can go to the home and see the patient. So there's a lot of different flexibilities around that. And I often think that agencies do not use that additional 30 days after the start of care date in an effective way. And so Jackie, when you give this advice to our clients in particular, do you ever get any pushback?
Oh, all the time. And again, that's why you're calling it a dilemma, because I think there is a lack of understanding completely. I'll get things like, well, we don't need the face-to-face attestation because we put that on the plan of care and the certifying physician signs off on that. It's like, whoa, no, no, no. Um, that's not that's not the issue, because if you're making notation in the plan of care that this is your particular face-to-face, if it's not valid to begin with, then you're just reinforcing that it's not valid, that you don't have it. So it is something you are supposed to have when you bring them on to service. The other thing is that I hear a lot is, well, we do PCR and we get approved all the time. Well, yeah, a lot of people do PCR and they'll do a placeholder diagnosis of hypertension until they get the chart completely coded accurately. So that's not going to lead you to knowing you have a valid face to face. It's one of those, okay, let's cross our fingers, cross all of our toes, hold our breath, and pray nobody really looks at it hard, because you just set it up for non-compliance right from the get-go. So
I absolutely love that, because it's important that you get this right from the get-go. It's important that you get a solid face-to-face as part of your certifying that patient for home health. That is something that has been in place since 2017, and it's a compliance box that everybody's trying to make into a ball. They're all trying to cut the corners off of it. And Terry, I'm going to bring you in here because your specialty and your love is assisting with audits. What happens if they ignore the advice that they're getting from reputable outsourcing, or ignore some of the dilemmas that can occur during compliance, and decide to move beyond that without having that document be solid? What kinds of things can happen to an agency?
Well, I, I've had this conversation so many times talking about coding and face-to-face. The face-to-face encounter has to be related to your primary reason for home care. So I'm, I'm, I will never be able to understand how a coder can code a record without the face-to-face encounter. If the face-to-face encounter is related to the primary reason for home care, where did the coder get the primary diagnosis, if not from that required document? So when you have a coding company or your in-house coder say to you, I don't have a valid face-to-face, you need to listen, because they're telling you that what's going to go on that 485 or that plan of care, that primary diagnosis is not supported by the face-to-face encounter. Face-to-face encounter is meant to establish eligibility for the Medicare home health benefit, right? These people are deadly serious about their money. And if you don't meet their rules, they're going to take away your money. And so when GainK, if that's your coding company and you'd be wise to use them, if they say to you, this isn't meeting the standard, I don't have what I need for that primary diagnosis, you need to listen to them and you need to get that additional documentation. It, we don't make that much money anymore. I mean, gone are the days, where you had a home health aide in there daily and therapy 3 week 9 for those days are gone. We have to manage our money carefully. The rules are out there. We know what the rules are. We need to follow them so that we can get paid for every single visit we do, every single patient we see. There's some things that are red flag. I agree about the 30 days post start of care, but when I'm reviewing a record that's going to go for review, or I'm doing an appeal, and I see that the face-to-face encounter was done after the start of care, I immediately go to look to see what date the certifying physician signed the plan of care. Because he cannot sign the plan of care until the face-to-face encounter's been done, right? The certification statement says the face-to-face established eligibility. So I go right away, because if that signature is before the face-to-face encounter date, your whole claim is invalid. I have no appeal argument for that. Really important, and because a lot of agencies, they want to do their pre-claim, they want to bill early, so they're getting that plan of care done, everything getting signed, and yeah, we're gonna get, I know this doctor, he's gonna do the face-to-face, no problem. It can't, but your plan of care can't be signed until the face-to-face encounter is done, be it 90 days before, 30 days after.
And Sherry, that's back
Yeah.
to what the point she just made is I push really hard for these agencies that will come back and say, okay, we'll send it over. We'll get the addendum to the face-to-face sign, because it might be that it's an addendum. It got sent over for gait instability, and we need to know, or maybe they identified wounds and we need an addendum because the wounds are going to be the primary focus of care, not the original. So you have to do that addendum, and we'll be, asked to go ahead and tentatively code, and put a note that that's what we've done. The issue with that is you're having to trust that the people within your agency will actually follow up and make sure it happens in the proper chronological process, so that that plan of care doesn't get signed until that's done. Because if you send that plan of care off and it's signed, and then you get the addendum or the documents back after that, like Carrie said, you have no defense. You can't appeal it.
And I want to be real clear with everyone. PCR is the pre-claim review that just opened up in Oklahoma this year. It's in 5 or 6 other states. And we honestly think that it's going to go nationwide. And it oftentimes you get a pre-claim review affirmation, but there's a statement on that affirmation, right, Terry, that's pretty clear?
It says it's provisionally affirmed. There is no guarantee that, should your record be called, that somebody's gonna look at it and somebody may determine that your face-to-face encounter was invalid, therapy was not medically necessary, whatever it is. It is a provisional affirmation, no guarantee.
Wow.
Although I highly recommend, for anybody who's trying to decide, because you have choices, remember that in pre-claim review, if you submit it and it's not right, the face-to-face not good enough, whatever it is, you can change the world as long as you haven't billed. So when you're looking at making a choice, if you're new to it or going to be new to it, when you choose that post-payment review option, I think there's a couple of them, once you build your claim, you can't change a thing. So it's burdensome. Trust me, it becomes easier the more you do it. It really does become easily integrated after, you got to deal with people's reluctance to change and a new process. But once you get there, you'll be fine. And you can change anything that they don't like. And you have a year and you can keep sending and sending. But once you build, that's it, you're done. And there's no way you can get a better note or a better whatever, another order, nothing. Once you build, you're done.
And Terry, that is a golden piece of advice for everyone on this call. We cannot bill until the 30th day anyway. This is not like the old days where we had a receipt of anticipated payment that we got 60% of the episode up front. Those of you that are new to home care, that's going to shock you. Yes, we got 60% of the estimated payment up front and billed the final 40% at the 60th day. Now we can't drop a bill until 30 days anyway. So you have that 30 days that face-to-face allows you to get the face-to-face correct before you have to submit your OASIS to the state. You have to submit your plan of care, all of those things. So building out a timeline and what needs to be satisfied in a checklist is not a bad idea. And Terry, what happens if you do get an ADR and your face-to-face system is not accurate or not compliant?
I'm, it's my firm belief, and I've not sat beside a single auditor. It's my firm belief that it's the first thing they're gonna look at, because it's between not submitting your records and an invalid face-to-face, that covers almost all of the denials, it seems.
Mhm.
So if you have a face-to-face encounter in an ADR that does not meet the standard, for heaven's sakes, if I mean, there's not quite good enough, and there's just really not there. If your primary diagnosis is diabetes, and the face-to-face encounter makes no mention of diabetes whatsoever, there's you got nothing.
Mhm.
If you have let's say one of the, I'm even trying to think,
Well, there is a dilemma. There's a
hypertensive crisis, right? And the doctor only mentions their hypertension and to continue their meds. But he might say to, log blood pressure. You can get an attestation from the physician, where he'll say that the reason that he wanted home health services was for the skilled nurse to monitor and assess blood pressure. And he'll sign it, and it'll be after the date you billed, and the date he signs will be after the date you billed. It likely you'll be denied, and then you'll appeal and you'll be denied. Maybe by the time you get to the Quick or Maximus, whoever it is, that they might agree. Maybe you'll go all the way to the ALJ, and maybe they'll agree. But that would be my advice, that if your face-to-face is not quite good enough, that that somebody's going to look at it and say it's invalid, get an attestation from the physician that describes why he ordered home health, and including the diagnoses that's your primary diagnosis for home care. Get him to sign it. It's signed after billing. There's no, you're not going fast and loose and trying to hide something. Never, ever, ever would I ever in an appeal or in an ADR misrepresent the care provided. All you got to do is lie or misrepresent, and then you're done. I mean, you're not going to build any goodwill or get any grace from these folks. So do the right thing. Get the attestation. It's your only option at that point.
It's your
And
protection.
Terry, didn't you say it's the lowest hanging fruit?
You guys are making fun of me. I say it all the time for a reason. I was saying to these guys this morning, auditors, not necessarily, our fiscal intermediary, but we might have a rack audit or whatever. These people make money when they take our money. It's really important that we not give them the opportunity to come back. An agency not associated with this company submitted to an insurance company, and there's a form that they use that lets the patient know about how face-to-face works, and that we have to have it, and the patient signs it. And when they submitted the records for the ADR, they didn't include the face-to-face encounter. They included this form the patient signs that says we need face-to-face. And they have, I mean, until now, they're still getting requests, because the insurance company said, if these folks don't even know what a face-to-face encounter is, we're going to look at all their records, because we're going to take back a bunch of money from them. So don't be low-hanging fruit. Somebody in your organization, more than one somebody, needs to know what the rules are. The patient who needs, we're seeing for hypertension, because the doctor wants to monitor because we've changed the medications, and it's important. We can monitor, but only for 3 weeks. I know that because that's what Chapter 7 tells me in the Medicare Benefit Policy Manual. You want to look at what the rules are for incorporating our documentation into the certifying physician's medical record. It says that right there in Chapter 7, where physical therapy, if you've got a good physical therapist and their documentation is there, doctor signs it, it's incorporated into his record, and you can use that as face-to-face support, because a lot of times homebound isn't everything we wish it would be in a physician or a non-physician practitioner's face-to-face encounter. Learn the rules, and then it'll be harder for people to take our money, and we'll be less likely to be low-hanging fruit.
And and I was gonna, you know, add on to that, Sherry, with one of your things. If you decide to give them, you know, the low hanging fruit, then you need to look at the auditors as short-term loan collectors.
That's right.
Yeah,
And
pretty much.
And basically, they can go back 3 years and extrapolate out to a percentage in a Z-pick beyond a rack audit, and really shut down your operations if you're not one of the ones that have a large venture capitalist backing you or something like that. And real quick, closing thoughts. If I gave you a magic wand, Jackie, what would you do to help agencies with the face-to-face?
Well, provide them with a CMS documentation, but also provide them with a very well written face-to-face addendum document that they can utilize. But it's one of those, just having them understand what is valid and what is not.
And a lot of
So
that information comes from the clinician when they go out to see the patient the first time, to really give the agency a good idea of exactly why home health and why now, right?
right.
So Terry, what about if I gave you the same magic wand? What would you give to agencies?
You know, you actually just stole my line. When you're looking at a face-to-face encounter document, it should be clear. Why home health? Why now? And that expression came from auditors at Palmetto. The question, why home health? Why now? Especially if you're looking at those documents that are 90, 80, 70, 60, 50, 40. If they saw the doctor that long ago, why do they need us now? It's never going to be enough that your primary reason for home care is just simply a diagnosis on a list. Look for the assessment where the doctors or the provider has put the diagnosis and talked about needs labs, needs therapy, needs whatever, needs to adjust meds. Look for those things. The face-to-face encounter visit does not have to say in the top line whatever your primary diagnosis is. It could say, annual wellness visit. That's fine. But look at what the doctor assessed. If it's not there, and it's sometimes you just need to decide if all he can give you is back pain, which doesn't pay in PDGM, or debility or weakness or gait ab. If this is all he can give you and there's nothing more, as difficult as this is to hear, you need to walk away. You need to say, I'm so sorry. I can't provide care because I will not be paid. And agencies are always, so timid about this. But I will tell you what, those doctors and providers, they get their money. They make sure they get their money. And we need to have that same kind of confidence that this is what the rules are, this is what we need. And if we can't do it, we can't see the patient. And I promise you, the doctor is not taking on patients he can't bill for.
100%. I could not agree more. And I just want to thank you, ladies, for being on this podcast with us. And hopefully this will resonate with an agency somewhere in the middle of America that's struggling with this issue. And understand that the professionals around you, your coding certified folks, your outsourcing providers that have certified coders, it is in our ethical statements that certain things have to be present in the chart in order for us to do the coding. Rely on those folks to keep you between those guardrails. Rely on those folks and listen to them about what information needs to be in the chart to protect your revenue. That's the key part of this, is protecting your revenue and protecting the care that the patient needs. So thank you, ladies, both. And we're going to sign off here, and everybody be careful out there in home health land.